Eisenmenger syndrome is an important complication of large left-to-right shunts which develop later due to development of pulmonary vascular obstructive disease and severe pulmonary hypertension. The first report of Eisenmenger was by Victor Eisenmenger in 1897, and that was in a 30-year-old person who later succumbed to massive hemoptysis. This highlights one of the most important complications of Eisenmenger syndrome, that is airway hemorrhage. Airway hemorrhage can occur in those who ascend to high altitudes and during air travel, but it commonly occurs at low level itself. It's one of the most important causes of mortality in Eisenmenger syndrome. Diagrammatic representation of VSD Eisenmenger. It's also called Eisenmenger complex. The other Eisenmenger syndromes are not called Eisenmenger complex. Only VSD Eisenmenger is called Eisenmenger complex. There is a large ventricular septal defect with severe pulmonary hypertension and reversal of shunt across the ventricular septal defect, producing cyanosis, clubbing, exertional dyspnea, and as already mentioned, hemoptysis is an important complication of Eisenmenger syndrome, airway hemorrhage, which is more likely to occur when the person ascends to high altitude and in air travel because of the lower atmospheric pressure. But if you go by the statistics, majority of the hemorrhages occur at sea level or ordinary level of height. That's because most of these persons do not go for mountain climbing or air travel. Diagrammatic representation of PDA with Eisenmenger syndrome. Importance in PDA with Eisenmenger syndrome is the shunting is going into the descending aorta. So there will be differential cyanosis and clubbing. Clubbing and cyanosis will be more in the lower limbs. Sometimes as the left subclavian is near the shunt, left upper limb can also be having cyanosis. Right upper limb cyanosis is less likely. That is PDA Eisenmenger syndrome with differential cyanosis and clubbing. Shunt reversal across AST occurring in severe pulmonary hypertension secondary to large left to right shunt, AST Eisenmenger syndrome. There are some important features differentiating AST Eisenmenger from the other two varieties. In AST, the shunt is established only when the right ventricular muscle regresses after birth. So it is a delayed onset of shunt, and larger shunts are common in large AST. As the pulmonary vascular regression occurs, by the time AST shunt is established, usually Eisenmenger syndrome is a very delayed complication of large AST. Some even say that those with Eisenmenger in AST are really those who are destined for primary pulmonary hypertension. But leave that alone. Large ASTs usually develop Eisenmenger syndrome maybe after decades, not like early development of Eisenmenger syndrome in VSD and PDA. Another important feature is that there is no connection between the ventricles or the pulmonary artery and the aorta. So, pressures here can go suprasystemic, that is, right ventricular pressure and pulmonary artery pressure can go suprasystemic in AST Eisenmenger. While in VSD Eisenmenger, it does not go beyond systemic level because the large VSD equalizes pressures in two ventricles. Similarly, in PDA Eisenmenger also, the systemic and pulmonary circulations are connected by the PDA, so that in PDA Eisenmenger also, maximum pressure possible is only systemic level in the pulmonary arteries. while in ASD there is an isolation. So in ASD Eisenmenger, suprasystemic pulmonary hypertension is possible. So they do badly, but it develops only very late and in very few also. There are several persons in 6th and 7th decade having ASD with still left to right shunt. They have heart failure sometimes. Another difference is that right atrium is grossly enlarged in ASD. It produces cardiomegaly on X-ray in ASD Eisenmenger. In the other two Eisenmenger syndromes, even though they may have cardiomegaly when there's a large left-right shunt in infancy, the cardiac size regresses when pulmonary hypertension develops and shunt decreases. So if you see cardiomegaly on X-ray in a Eisenmenger syndrome, most likely it is ASD Eisenmenger, mostly contributed to large right atrium, which enlarges towards the right and produces cardiomegaly in ASD Eisenmenger. So two features, one is cardiomegaly, second is suprasystemic pulmonary pressures in ASD Eisenmenger. Then in PD Eisenmenger, you can have aortic enlargement because the shunt is received in the region of the aortopulmonary region. Aorta can be enlarged in PD Eisenmenger. In VSD Eisenmenger, there is no aortic enlargement, there is no cardiomegaly. And in PD Eisenmenger, sometimes you can see the ductal calcification. Inverted Y-shaped ductal calcification may be seen sometimes in persons with PD Eisenmenger. Moving on to important complications in Eisenmenger syndrome. Airway hemorrhage, that is to even massive airway hemorrhages. It can also be mild hemoptysis or massive hemorrhage, which can cause choking and mortality. Mortality is usually due to airway obstruction, due to clots, rather than due to the amount of bleed. It is a very catastrophic event in Eisenmenger syndrome, and it was described from the very first report of Eisenmenger syndrome that has already been discussed. Decompensated erythrocytosis is something which we see very often. That is, there is renal ischemia due to clogging of capillaries, which leads to increased erythropoietin secretion, and this causes decompensated erythrocytosis. Another feature is that if you do venesection for removing the excess RBCs to reduce the symptoms of hyperviscosity, there is a temporary improvement. But then erythropoietin secretion increases further and you can have a decompensated erythrocytosis. So venesection for Eisenmenger syndrome is a double-edged situation. Unless it is carefully taken care of, it can cause decompensated erythrocytosis, which is a vicious cycle. Iron deficiency causes microcytes, and microcytes are less deformable, and when they go through the capillaries, they can cause renal ischemia and increase in erythropoietin secretion, further rising the hemoglobin levels. And thrombotic strokes are also an important complication due to hyperviscosity, and they are more likely to occur if there is iron deficiency. So one has to be very careful about avoiding iron deficiency in those with Eisenmenger syndrome. Thrombotic stroke prevention, in that case also, avoiding iron deficiency is important. Coagulation abnormalities can be seen because there are platelet function abnormalities in Eisenmenger syndrome. Then brain abscess is an important complication which can occur in Eisenmenger syndrome. And because of the large cell turnover, there is also a possibility of hyperuricemia and related symptoms in persons with Eisenmenger syndrome. And regarding thrombotic stroke, one important aspect is that if the persons undergo contrast angiography, they are likely to have higher risk of thrombotic stroke. This is because of hemoconcentration. So adequate hydration is very important, especially in all cyanotic persons undergoing contrast angiography to avoid periprocedural thrombotic stroke.